Imagine this, a hidden plumbing issue inside a dog, maybe your dog, a detour in their bloodstream that, well, they might not even show a single sign of.
Yeah, it's quite something. The sources say up to 20% of dogs with this vascular quirk live their lives seemingly unaffected.
That hidden nature, that silent anomaly, that's exactly what we're plunging into today on the deep dive.
We're tackling congenital portosystemic vascular anomaly, or PSVA for short.
PSVA.
Okay.
Think of it like this. Normally, blood from the digestive system goes straight to the liver, right? It's the body's ultimate filter.
Right. Cleans everything up.
But with PSVA, you've got these unexpected shortcuts, these sort of abnormal blood vessels that let that blood bypass the liver entirely.
So the crucial job of cleaning out toxins, it just
Yeah.
doesn't happen properly.
Exactly, it gets skipped.
Okay. And to really understand these hidden highways and,
Cool.
their impact, we've been digging through some pretty detailed medical texts.
The core literature. Our mission here is to really map out this condition for you so you can grasp the essentials of PSVA, what these detours are, what happens when they occur, and why it's something worth understanding.
And we'll try to keep it engaging, hopefully hit some of those aha moments.
Yes, definitely. Okay, so let's get down to the nitty-gritty. What actually triggers these blood vessels to take the scenic route instead of going to the liver?
Well, at the heart of PSVA is something called hepatofugal circulation.
Hepatofugal. Okay, sounds technical.
It does make, think of fugal, like fugitive. It's blood flow literally running away from its usual destination, the liver.
Ah, okay. Running away. Got it.
Normally, we want hepatopetal flow, blood heading towards the liver. So these abnormal connections, these shunts, can happen in two main places.
Right.
Outside the liver, we call those extrahepatic shunts. They're more common in smaller dog breeds and cats.
Extrahepatic outside, small breeds. Yeah.
Or they can be inside the liver itself. Those are intrahepatic shunts, and we tend to see those more in the larger breeds.
Intrahepatic inside. Large breeds. Makes sense.
And usually, in most cases, it's just one single rogue vessel causing all the trouble.
Just one. Huh. Now, here's where it got really interesting for me in the reading. Our sources point out that many small breed dogs with this PSVA also have something called microvascular dysplasia, MVD.
Ah, yes.
MVD.
That sounds like we're peeling back another layer. What's the connection there?
That's a really great point. Think of PSVA as a problem with the major highways, the big blood vessels going to or from the liver.
Okay, the main roads.
Now, MVD is like having issues on the tiny, intricate back roads within the liver itself, the really small blood vessels, the capillaries.
Little side streets inside the liver tissue.
Exactly. And in many small breeds, it seems these two conditions can be linked. Perhaps there are different ways a broader genetic tendency towards vascular abnormality shows up.
So it's inherited.
Yeah, it's often inherited as what we call a complex polygenic trait. That just means multiple genes are likely involved. It's not a simple one gene thing.
Right, not straightforward. And importantly, we need to make sure we don't mix up this congenital PSVA, the kind they're born with acquired portosystemic shunts, or APSS.
Acquired ones. How are they different?
Those develop later in life, usually because there's increased pressure in the main vein bringing blood to the liver. That's called portal hypertension. The body sort of creates bypasses under pressure.
Ah, okay, so the body makes its own detours later on because of high pressure.
Precisely. But those aren't congenital, and they're not our focus today. But circling back to the congenital form, that genetic basis in certain small breeds really underscores that inherited piece of the puzzle.
Okay, so with this blood flow taking a detour from birth, what are the immediate consequences inside the body? What essential jobs are getting skipped?
Well, the big one is that the liver misses out on its chance to detoxify various substances, particularly nitrogenous toxins.
The nitrogenous toxin, like waste products.
Exactly. They're produced in the intestines mainly from breaking down food, especially proteins, waste products, basically.
And normally the liver cleans those up.
Right. But when the blood carrying these toxins bypasses the liver through the shunt, they just end up circulating through the rest of the body.
Not good.
Not good at all. And this shunting also leads to something called microhypatia.
Microhypatia.
Yeah.
Small liver.
You got it. A smaller than normal liver. Think of the blood coming from the intestines as delivering not just nutrients, but also like growth signals to the liver. The text calls them hepatotrophic factors.
Growth factors for the liver.
Yeah. So if that blood flow is diverted away, the liver doesn't get those signals properly, and it just doesn't develop to its full size.
Huh. So the detour stunts the liver's growth too.
In a way, yes.
And those built-up toxins, the ones circulating, They can cause some pretty significant issues then, right? Our source mentions hepatic encephalopathy, or HE. That sounds quite serious.
It can be, yeah. Hepatic encephalopathy, or HE, happens when those unfiltered toxins reach the brain.
Toxins affecting the brain.
Okay. It's often episodic, which means it kind of flares up and then might subside for a while.
Comes and goes.
Right. And these episodes can be triggered by certain things, like eating a high-protein meal.
Because that makes more of those nitrogenous wastes.
Exactly. Or things like gastrointestinal bleeding, getting dehydrated, electrolyte imbalances, even certain medications can sometimes trigger an episode.
Wow, okay. So lots of potential triggers.
Definitely. And another key consequence we see is the formation of ammonium biurate crystals in the urine.
Crystals in the urine.
Yeah. These can sometimes clump together and form bladder stones or even kidney stones. That condition is called urolithiasis.
Stones. Okay, why does that happen?
It happens because the liver isn't doing its job efficiently. Part of its job is converting ammonia and uric acid into urea, which is much more water-soluble and easily gotten rid of in urine.
So if the liver's bypassed, the ammonia and uric acid build up.
Correct. And that leads to higher levels in the blood and urine, causing these specific ammonium biurate crystals to form.
And sometimes, you mentioned the urinary problems are the first clue.
Absolutely. Sometimes the presenting complaint, the reason the owner brings the pet in, is difficulty urinating or blood in the urine because of these crystals or stones.
Interesting. So it might not look like a liver problem at first glance?
Not always, no. And it's really important to remember the severity of all these signs, the HE, the stones, it really depends directly on how much blood is actually being shunted away from the liver.
Yeah.
The size of that detour matters.
Right, the percentage of blood taking the bypass. Okay, so if someone has a pet with PSVA, what kind of signs might they actually observe day to day? Which body systems are most likely to show effects?
Well, we see impacts across several systems. The nervous system, as we discussed with those episodes of hepatic encephalopathy.
The brain signs.
Yes. Then gastrointestinally, you might notice things like intermittent loss of appetite, maybe vomiting or diarrhea, sometimes really strange cravings like trying to eat dirt or rocks, that's called pica,
Eating non-food items, right?
or excessive drooling, that's called pyelism, and it can be particularly noticeable in cats.
Drooling in cats, okay.
Then the urogenital system can be affected too. Veterinarians might feel kidneys that seem a bit plump on examination, and of course those ammonium urate stones we talked about.
Plump kidneys and stones.
And interestingly, one report we looked at highlighted that about 50% of male dogs with PSVA had cryptorchidism.
Cryptorchidism. That's undescended testicles.
Correct. One or both testicles don't descend properly into the scrotum, so quite a link there in that study.
Huh. That's unexpected.
It is. But, and this is crucial, circling back to our start, it's absolutely vital to remember that up to 20% of dogs with this condition can show absolutely no outward signs at all. Zero.
That's just amazing. Such a broad spectrum from seemingly nothing wrong to all these potential issues.
Exactly.
What about the animal's history then? If a vet is talking to an owner, are there any common threads or patterns in the background story that might make them suspect PSVA?
Yeah, definitely. Stunted growth is a really common historical finding. Maybe the owner mentions this puppy was always the runt of the litter or just didn't grow like the others.
Smaller than expected.
Right. Often, the signs might start to appear or become more obvious after a puppy or kitten transitions from their mother's milk onto commercial food.
Why then specifically?
Well, commercial foods are typically higher in protein than milk, which can increase that nitrogenous waste load we talked about, potentially overwhelming the system when the liver isn't filtering properly.
The diet change unmasks the problem.
It can, yes. In cats, that excessive drooling, the pyelism, might initially be mistaken for something simple, like a cold or an upper respiratory infection.
Right, because drooling isn't the first thing you think of with liver disease.
Not usually, no. And the way hepatic encephalopathy presents is also quite characteristic, these sort of dramatic but temporary periods of illness. The pet seems really out of it, maybe disoriented, weak.
The episodic nature again.
Exactly. They might improve with some supportive care, maybe fluids or medication, only for the signs to potentially return later.
Yeah. And what specific signs make up that HE episode?
The central nervous system signs we see with HE can include things like just general weakness, lethargy, maybe aimless pacing or circling, disorientation.
Staring into space, maybe?
Yeah, or pressing their head against walls or furniture. That's quite a classic sign. And in more severe cases, you can even see seizures or the animal falling into a coma.
Wow. That sounds scary.
It can be very distressing for owners to witness. And then, related to the urinary system, owners might report their pet is drinking way more water and urinating more frequently.
Increased thirst and urination.
Yes, or they might notice signs of discomfort or straining when urinating, maybe blood in the urine, because of those crystals or stones causing irritation or blockage.
So a lot of potential clues in the history.
Definitely. Gathering a thorough history is key.
And what about the physical examination itself? When the vet actually puts hands on the animal, are there any telltale signs they might pick up on?
Well, here's the tricky part. Again, the physical exam can be surprisingly normal in some cases.
Even with all that going on inside.
Yes, an animal can have PSVA and still appear, bright, alert, perfectly healthy on the surface.
Huh.
However, things we do often note are that stunted growth, being underweight or smaller than their litter mates, and the vet might be able to feel or palpate a smaller than expected liver, that microhypatia again.
Feeling for the liver size.
Right. And in cats, specifically cats that don't normally have blue eyes, there's mention in the literature of potentially seeing copper-colored irises.
Copper eyes in cats. That's specific.
It is, though it's really important to know that this can be a normal iris color in certain breeds, like Persians or Russian blues, for instance. And treating the PSVA won't change the iris color if it was just normal for that cat's breed.
Good clarification. So not a guaranteed sign.
No, definitely not. And another thing, a sites that's a buildup of fluid in the abdomen, making the belly look swollen, that's actually a pretty rare finding in uncomplicated PSVA. If we see that, it might suggest other things are going on, maybe other complications or a different underlying issue.
Okay. So mostly subtle signs on exam or maybe none.
Often, yes. It reinforces why history and diagnostics are so important.
So we know PSVA is something they're born with, congenital. But are certain animals just more prone to developing it? Are there specific breeds we should know about that are considered high risk?
Oh, absolutely. There are definite breed predispositions. Overall, it's more common in dogs than in cats.
Dogs more than cats.
And when it comes to dogs, many smaller breeds have a higher incidence. The list is quite long, actually.
Let's hear some examples.
Sure. Yorkshire Terriers are a big one. Cairn Terriers, Maltese, Tibetan Spaniels, miniature Schnauzers, Norfolk Terriers, Pugs, Shih Tzus, Havanese, Papillons, quite a few of the popular small breeds.
Wow, yeah, lots of familiar names there. What about larger dogs?
For the larger breeds, we tend to see it more often in Irish Wolfhounds, Labrador Retrievers, and Old English Sheepdogs. Those are the main ones highlighted.
Irish Wolfhounds, Labs, Old English Sheepdogs,
Variere.
and age.
Yeah.
Is it always diagnosed in puppies and kittens?
Usually, yes. It's typically diagnosed in young animals, often under a year old, because that's when signs might start showing up, especially after weaning.
Makes sense.
However, sometimes it can be identified much later in life. We've seen cases diagnosed in dogs as old as, say, 13 years.
13? Really? How does that happen?
Well, often those are the animals that don't show any symptoms, the asymptomatic ones we keep mentioning.
Ah, the 20%.
Exactly. They might get diagnosed incidentally, perhaps during blood work for something else entirely, or maybe during a pre-anesthetic screening.
Found by accident, basically.
Pretty much. Miniature Schnauzers are mentioned as a breed where diagnosis might sometimes occur later, and there's a specific type of shunt called a portoazygous shunt that also seems to be associated with a potentially later diagnosis sometimes.
Interesting. So not always a puppy disease.
Not strictly, no, although most
Why not?
symptomatic cases are young.
Okay. Given this really wide range of potential signs, or, the complete absence of them sometimes, how do veterinarians actually go about diagnosing PSVA? It sounds like it could be quite a detective process.
It really can be, and that's why considering other potential causes for the signs, we're seeing what we call differential diagnoses is really important first.
Ruling other things out.
Exactly. If you have neurological signs like seizures, you need to think about infections, maybe exposure to toxins, metabolic problems, even epilepsy.
Right.
If it's gastrointestinal upset, could it be just a simple diet change, parasites, inflammatory bowel disease, or something more serious like a blockage?
Lots of possibilities for tummy trouble.
For sure. And urinary issues, well, they might just be a straightforward bacterial bladder infection or maybe different kinds of bladder stones.
So you check for the common stuff first.
Always. However, when we start to suspect a liver issue specifically, perhaps because of the breed, the history, or some initial screening tests, that's when certain lab results become really crucial, especially things like liver function tests.
Okay, so specific tests point towards the liver.
Yes. And particularly, a significantly elevated level of total bile acids in the blood can be a very strong indicator of a possible portosystemic shunt. That's often a key trigger for more investigation.
Total bile acids.
Yeah.
You mentioned that as being really sensitive. What other key laboratory tests give veterinarians important clues when they're investigating PSVA?
Right. Beyond bile acids, several other blood and urine tests add valuable pieces to the puzzle.
Okay, like what?
Well, in a complete blood count, the CBC, we might see something called microcytosis.
Glycocytosis. Small red blood cells.
Exactly. Red blood cells that are smaller than normal. And
Mhm.
sometimes we see a mild anemia, meaning a lower than normal red blood cell count.
Okay. Small cells, maybe fewer cells.
In cats, specifically, we might see oddly shaped red blood cells. That's called poikilocytosis. And in dogs, sometimes we see what are called target cells. They have a dark center and a dark outer ring, looking a bit like a bullseye.
Weird shapes and targets. Got it.
Yeah.
What about the chemistry panel?
On a blood chemistry panel, which looks at organ function and electrolytes, finding low levels of blood urea, nitrogen, BUN, and creatinine, and also low cholesterol are pretty common findings with PSVA.
Low BUN, creatinine, cholesterol. Why low?
Well, BUN and creatinine are related to protein metabolism and kidney function, which can be altered. And the liver makes cholesterol, so poor liver function can lead to lower levels. But it's important to say these aren't always present. You can have PSVA with normal levels.
Okay. Common, but not guaranteed.
Right. Low blood sugar hypoglycemia is less common, but can happen sometimes. Liver enzyme activities, particularly one called alkaline phosphatase, or ALP, might be elevated, especially in young, growing animals where it's normally a bit higher anyway.
High ALP.
Yeah. But another liver value, bilirubin, which relates to jaundice, is usually normal in uncomplicated PSVA.
Okay. And the urinalysis. You mentioned crystals before.
Yes, the urinalysis is often very informative. We frequently see dilute urine because the kidneys might not be concentrating urine properly, and finding those telltale ammonium biurate crystals is a big clue.
The spiky-looking ones.
Those are the ones. You might also see signs of secondary issues like blood, white blood cells indicating inflammation, or protein in the urine, maybe from irritation caused by the crystals, or a secondary infection.
So the urine sample gives a lot of info, too.
Definitely. Putting the CBC, chemistry, and urinalysis together builds a picture.
And you highlighted total bile acids, TSBA, as a particularly sensitive indicator. Why is that specific test so important in diagnosing PSVA?
Right. TSBA is indeed a very, very sensitive marker for portosystemic shunting. It's probably the single most useful screening blood test.
Why does it work so well?
Okay, so bile acids are made in the liver, then secreted into the intestines to help digest fats. Normally, after doing their job, they get reabsorbed from the intestines back into the portal blood, go straight back to the liver, and the liver efficiently pulls them out of circulation. It's called enterohepatic circulation.
A recycling system.
Exactly. But if a significant amount of that portal blood is bypassing the liver through a shunt.
The liver doesn't get a chance to pull them out.
Precisely. So these bile acids aren't cleared efficiently from the bloodstream, and their levels rise significantly, especially after a meal when the gallbladder contracts and releases a surge of bile acids for digestion.
Ah, hence the test after eating.
Correct. We often do what's called paired sampling. We take a blood sample after the animal has fasted for about 12 hours, get a baseline level. Then we feed them a small meal, usually something fatty to stimulate biorelease, and take another blood sample about 2 hours later.
Fasting and post-meal samples.
Yes. And in animals with PSVA, those post-meal bile acid levels are typically very, very high, often way above 100 micromoles per liter, which is significantly elevated compared to normal.
Wow, okay. That sounds like a clear indicator then.
It's a very strong indicator, highly suggestive of shunting. Now, measuring blood ammonia levels can also be useful, especially if the animal is showing signs of HE, because ammonia is one of those key toxins not being cleared.
Ammonia levels.
But ammonia testing can be a bit tricky in practice. The samples have to be handled very carefully, kept on ice, processed quickly, otherwise you can get falsely high results. So it's maybe less reliable or practical than bile acids in a general practice setting.
Handling issues, okay.
There's also something called an ammonia tolerance test, where a small amount of ammonium chloride is given orally or rectally, and then blood ammonia is measured to see if the body can process it. But this carries a slight risk of actually triggering temporary HE signs, so it's done cautiously.
Maybe not the first choice then.
Probably not. Bile acids are usually preferred. And another really useful blood test that's emerged is measuring protein C activity.
Protein C, what does that tell us?
Protein C is an anticoagulant protein made by the liver. Its activity tends to be significantly low, usually below 70% of normal in dogs with macroscopic PSVA, the kind we're talking about. But it's often normal or only mildly decreased in dogs with that microvascular dysplasia, the MVD we discussed earlier.
Ah, so it helps differentiate between the big shunt, PSVA, and the tiny vessel problem, MVD.
Exactly. It can be really helpful in that regard, especially in those small breeds where both can occur.
That's neat.
Interestingly, protein C levels can sometimes be normal in dogs with PSVA that aren't showing any symptoms. And we also use this test after surgery.
To see if the surgery worked.
Yeah, to help assess if blood flow to the liver, the hepatopetal flow, has improved after ligation. If the protein C level increases significantly after surgery, it's a good sign.
Okay, that's a useful marker then, pre and post-op.
Mm-hmm.
So the blood tests give us some really strong clues pointing towards a shunt. What about actually seeing the problem, looking inside the body? What can imaging techniques reveal about PSVA?
Right, imaging is vital. Once blood tests suggest a shunt, imaging is usually the next step to confirm it, and crucially, to figure out exactly where the abnormal vessel is and what type it is.
Confirm and locate. What are the options?
Well, starting with the basics, regular abdominal x-rays or radiographs, they might show that smaller than normal liver, the microhypatia, which is often more noticeable in dogs than in cats.
Okay, small liver shadow.
And sometimes you might see enlarged kidneys, renomegaly. We might also be able to see those ammonium urate stones if they're large enough, but they are often radiolucent.
Radiolucent, meaning they don't show up well on x-rays.
Exactly. They don't block the x-rays much, unlike some other types of stones, so they can be hard to spot on plain films. You might just see the bladder shape.
Okay, so x-rays give some hints, but maybe not definitive.
Correct. For a long time, the gold standard for confirming PSVA and mapping the shunt was radiographic portovenography, specifically mesenteric portography.
Portovenography. Sounds invasive.
It is. It involves surgery to inject a contrast dye directly into a vein in the intestines or spleen, and then taking rapid sequence x-rays to watch where the dye flows.
Watching the blood flow path live on x-ray.
Essentially, yes. It clearly shows the abnormal vessel bypassing the liver and going, say, straight to the vena cava or the azygos vein. And it helps determine if the shunt is extrahepatic or intrahepatic based on its position relative to a specific vertebra, usually T13, as a landmark.
Okay, so that was the old standard. What about now?
Well, it's still a very good technique, but requires surgery just for diagnosis. Nowadays, abdominal ultrasound is very commonly used and can be extremely helpful, although it can be technically challenging.
Ultrasound. Less invasive.
Much less invasive, yes. No surgery needed, usually just sedation. An experienced ultrasonographer might see the small liver, maybe notice it looks less vascular than normal, what we call hypovascular.
Fewer blood vessels visible inside.
Right. And sometimes they can actually directly visualize the abnormal shunt vessel itself, tracing it from the portal vein to where it connects into the systemic circulation. But it can be tricky to find, especially if it's small or deep.
What helps make ultrasound better for this?
Specialized techniques really enhance it. Using color flow Doppler shows the direction and speed of blood flow, which can highlight the abnormal turbulent flow within the shunt.
Doppler shows the detour in action.
Exactly. And we can also use microbubble contrast studies. Tiny gas bubbles are injected intravenously, and they show up brightly on ultrasound, allowing us to see the blood flow pattern much more clearly and confirm that rapid shunting is happening.
Cool. Ultrasound with enhancements. What else?
There's also nuclear scintigraphy, either colorectal or splenoportal scintigraphy.
Nuclear medicine.
Yes. A small amount of a radioactive isotope is administered, either rectally or injected into the spleen, and then a special camera tracks where the radioactivity goes.
Following the radioactive blood flow.
Correct. In PSVA, the isotope typically bypasses the liver almost entirely and shows up in the heart very quickly. We can calculate a shunt fraction, the percentage of blood bypassing the liver, which is usually high, often above 60%, in significant shunts.
So it quantifies the bypass.
It does. Scintigraphy is very sensitive for detecting that shunting is occurring. The downside is it doesn't always tell you the precise anatomical location or type of the shunt, just that it's happening, and it requires specialized facilities.
Okay, sensitive for detection, less so for anatomy.
Right. Which brings us to what many now consider the new gold standard for imaging PSVA, multisector CT angiography.
CT scan like in human medicine.
Exactly, computed tomography. This requires a short general anesthetic because the patient needs to be perfectly still and involves injecting an intravenous contrast agent.
Contrast dye again.
Yes, but injected into a peripheral vein, not directly into the portal system like portovenography. The CT scanner takes incredibly detailed cross-sectional images, and computer reconstruction gives us beautiful 3D views of the blood vessels.
3D maps of the plumbing.
Pretty much. It provides excellent visualization of both the normal arterial and portal circulations and pinpoints the PSVA, its origin, its path, where it inserts with great accuracy. It's fantastic for surgical planning.
So CT is now top tier for detail.
It really is, offering a non-invasive, apart from the anesthesia and IV contrast, way to get a very complete picture.
Okay. So lots of imaging options. What about more invasive diagnostic procedures? Are things like liver biopsies helpful in diagnosing PSVA itself?
That's a good question. Taking a small sample using just a needle, what we call fine needle aspiration or FNA, isn't typically helpful for diagnosing PSVA. You might get some liver cells, but it doesn't tell you about the blood vessel structure.
FNA is out then.
Generally, yes. However, obtaining actual tissue samples, surgical or laparoscopic liver biopsies is often needed for a definitive diagnosis and to assess the degree of liver change. Ideally, samples should be taken from multiple liver lobes.
Why biopsy if imaging shows the shunt?
Several reasons. It confirms the microscopic changes in the liver that result from the reduced blood flow. It helps rule out other concurrent liver diseases. And importantly, it helps differentiate PSVA from MVD because remember, MVD involves microscopic vessel abnormalities within the liver, which you can only see on biopsy.
So the biopsy confirms the consequences on the liver tissue and checks for MVD.
Precisely. It gives you the full picture of what's happening both macroscopically, the shunt, and microscopically, the liver tissue response.
Okay. So if a liver biopsy is performed, what exactly do pathologists look for under the microscope? What are the key features that shout PSVA?
Well, first, looking at the liver grossly, meaning with the naked eye during surgery, perhaps, it usually just appears small and smooth.
The microhypatia again.
Yes, but under the microscope, the changes are quite characteristic, though not unique to PSVA, as we'll see. Pathologists typically see that the portal venules, the small veins within the liver's portal triads, are either very small, hypoplastic, or sometimes even completely absent.
Tiny or missing veins.
Right. But often they'll find an increased number of portal arterioles, the small arteries, in those same areas. It's like the liver is trying to compensate for the lack of venous flow by increasing arterial supply, maybe?
More arteries, fewer veins. Interesting imbalance.
It is. They also look for what are described as juvenile or underdeveloped portal triads. The whole functional unit just looks immature.
Like it never fully developed.
Kind of, yeah. Other common findings include lobular atrophy, a shrinking of the liver's main functional units, the lobules, because they aren't getting enough blood flow and nutrients. And you often see scattered clusters of inflammatory cells mixed with fat droplets called lipogranulomas.
Atrophy and inflammation spots.
Okay. Now here's the crucial point we touched on. The microscopic features of PSVA and microvascular dysplasia, MVD, are virtually identical.
Identical under the microscope.
Yes. Both conditions result from reduced portal blood flow to the liver tissue, so they cause the same kind of microscopic damage, the small venules, extra-arterioles, atrophy.
So the biopsy alone can't tell PSVA from MVD.
Correct. This really highlights why you need to put all the pieces together. You need the clinical picture, the signalment, breed, age, the blood tests like bile acids and protein C, the advanced imaging like CT or ultrasound showing a macroscopic shunt vessel, and the biopsy findings.
That's the whole package.
Exactly. MVD is essentially a diagnosis made by finding those characteristic microscopic liver changes in the absence of a large identifiable shunt vessel on imaging, often in a predisposed small breed dog with high bile acids.
Okay, that makes sense. Biopsy confirms the liver changes. Imaging finds or doesn't find the big shunt.
You've got it. Clinical correlation is key.
All right, so let's say we've gone through the diagnostics, we've put the pieces together, and we've arrived at a diagnosis of PSVA. What happens next? What are the different treatment options available?
Okay, treatment. It usually involves a multi-pronged approach. Managing their diet is fundamental. Using medications is often needed, especially to help manage any episodes of hepatic encephalopathy. And then, in many cases, surgical intervention is considered to try and finally correct the abnormal blood flow.
Diet, meds, and surgery.
Yeah.
Let's start with diet.
Providing the right nutritional support is absolutely crucial. This typically means feeding a diet that's restricted in protein.
Less protein.
Remember those nitrogenous toxins that build up? They mainly come from protein breakdown. So reducing the protein load lessens the amount of toxins the body has to handle when the liver isn't filtering properly.
Okay, reduce the source of the toxins?
Exactly. But you can't restrict protein too much, especially in growing animals, because they still need it. It's a balance. These diets are usually prescription diets specifically formulated for liver support. They often use highly digestible, high-quality protein sources like soy or dairy rather than lots of meat.
Special liver diets.
Yes. And they often have other modifications too, like added zinc or antioxidants. For dogs, sometimes veterinarians will recommend gradually reintroducing small amounts of easily digestible dairy protein, like cottage cheese, based on how the individual dog tolerates it and responds.
Tailoring the protein level.
Right. Diet is really a cornerstone of management, whether or not surgery is performed.
Okay. What about the medical versus surgical decision?
That's a really important conversation for the veterinarian to have with the owner. They need to thoroughly discuss both the medical management options diet and medications primarily, and the surgical option. Each has pros and cons.
Weighing the options.
Yes. Surgical ligation, which involves carefully tying off or closing the abnormal shunt vessel, has the potential to be curative, especially for symptomatic dogs. If you can successfully redirect most or all of the blood back through the liver, you can resolve many of the clinical signs.
Surgery offers a potential cure.
It does, for dogs who can tolerate the procedure well. However, it's important for owners to understand that even after successful surgery, some ongoing medical and dietary management might still be necessary, at least for a while.
Not always a complete fix immediately.
Not always, and critically, there are significant surgical and anesthetic risks involved. The reported mortality rates associated with PSVA surgery can range anywhere from about 5% up to maybe 25% in some studies, depending on the type of shunt, the patient's condition, and the surgical technique used.
5 to 25% risk. That's quite a range.
It is. It's major surgery with potential complications. We talked about monitoring protein C levels after surgery. That can help assess if the ligation has been successful in improving blood flow to the liver.
Right, the protein C check.
And another consideration, if surgery isn't an option, maybe due to cost, risk, or patient stability, or if it isn't fully successful, there's that ongoing risk of those ammonium biurate crystals forming blockages in the urinary tract.
The scone blockages.
Yes, and particularly in male dogs, because their urethra is longer and narrower, this might unfortunately necessitate a permanent surgical opening called a perineal urethrostomy to allow urine to pass if they keep blocking. So that's a potential long-term consequence of non-surgical management sometimes.
A permanent urinary opening.
Right.
That's a serious consideration, too.
Definitely part of this discussion.
So surgery sounds like a significant step. It's promising, but carries real risks. What are some of the key things vets and owners need to consider during and immediately after a surgical correction?
Good question. First off, optimizing the patient's condition before surgery is critical, especially if they're experiencing hepatic encephalopathy. You need to get that under control medically. First, with diet and medications like lactulose or antibiotics, you want them as stable as possible going into anesthesia.
Stabilize before operating. Makes sense.
Absolutely. Then, post-operatively, very close monitoring is essential. Usually this means recovery in an intensive care unit, ICU setting, for at least 72 to 96 hours, so 3 to 4 days.
ICU monitoring post-op. Why so long?
Because some serious complications can arise in that immediate post-op period, the ideal surgical outcome is to completely close off or ligate the shunt vessel, redirect all that blood back to the liver.
Full closure.
But sometimes the body, specifically the portal system feeding the liver, can't handle that sudden increase in blood flow and pressure all at once. The liver might not be ready for it after being bypassed for so long.
Too much pressure too quickly.
Exactly. It can lead to severe, potentially fatal portal hypertension. So surgeons often have to perform only a partial ligation, closing the shunt vessel partway initially.
Partial closure instead.
Yes. They'll carefully assess how well the animal is tolerating the clamping of the shunt during the surgery itself, by monitoring blood pressure, heart rate, and even directly measuring the pressure in the portal vein before and after clamping. Based on that, they decide whether full or partial ligation is safest.
Okay, judged during the operation.
There are also devices like Amyloid constrictors or cellophane bands that can be placed around extrahepatic shunts. These are designed to cause gradual closure over several weeks as scar tissue forms around them.
Gradual closure devices.
Yes, the idea is to allow the portal system to adapt more slowly. However, even these can sometimes lead to complications, including the development of those acquired shunts later on if the closure isn't quite right or the pressure remains high.
Ah, potential for new shunts later.
It's a possibility. For intrahepatic shunts, which are often harder to access surgically, a technique called transvenous coil embolization is an alternative.
Coils, like in arteries.
Similar idea. Using fluoroscopy, live X-ray guidance, small thrombogenic coils are placed inside the shunt vessel via catheters inserted through neck veins, aiming to block off the blood flow. It's less invasive than open surgery, but might require multiple procedures and can be more costly.
Coil blocking for internal shunts.
Correct. And during the surgery, whichever method is used, performing intraoperative portography, injecting that contrast dye again while the shunt is clamped, is often advised.
Checking the work during surgery.
Exactly. It confirms that the correct vessel has been ligated and that blood is now flowing properly to the liver. You don't want to accidentally tie off the wrong thing.
Definitely not. Okay, what are the big post-op complications they're watching for in the ICU?
Several potentially serious ones. That acute portal hypertension we mentioned if the shunt is closed too much too quickly. Blood clots forming in the portal vein thrombosis. Seizures are unknown, they're not fully understood, complication that can occur 24-72 hours post-op, particularly in dogs.
Post-op seizures. Scary.
They can be. Also, things like lack of blood flow to the intestines, mesenteric ischemia, the release of bacterial toxins into the bloodstream, endotoxemia, infection, inflammation of the pancreas, pancreatitis, and gastrointestinal bleeding.
Quite a list.
It is. And one more practical thing, especially in these often very small young patients' hypothermia, they lose body heat easily under anesthesia and during surgery, so keeping them warm is critical.
Keeping them warm. Got it. So intensive care is definitely needed.
Highly recommended, yes.
And what about medications? You mentioned using them before surgery. Are there specific drugs commonly used to manage PSVA long-term, perhaps if surgery isn't done?
Yes, medications play a key role in managing the symptoms, particularly the hepatic encephalopathy, whether it's pre-op, post-op, or for long-term medical management.
Right.
While we won't get into specific drug names and doses in this overview, the mainstays usually include things like lactulose syrup.
Lactulose. How does that help?
Lactulose works in the gut. It acidifies the colon, which traps ammonia as ammonium ions so they aren't absorbed as readily. It also acts as a laxative, helping to move stool along faster, reducing the time for toxin production and absorption.
Traps ammonia. Speeds things up. Clever.
It is quite effective. Certain antibiotics, like neomycin or metronidazole, might also be used sometimes, usually short-term or intermittently.
Antibiotics. For HE.
Yes, the idea is to reduce the population of bacteria in the gut that produce ammonia and other toxins as they break down protein remnants.
Fewer toxin-producing bacteria.
Exactly. So diet, lactulose, and sometimes antibiotics form the core of medical HE management. And it's also really, really important for vets to remember that the way the body processes and eliminates other drugs can be significantly altered in animals with PSVA and liver dysfunction.
Because the liver isn't doing its drug metabolism job properly.
Precisely. The liver plays a huge role in breaking down many medications. If it's bypassed or not functioning well, drugs can stick around longer or reach higher levels, increasing the risk of side effects. So drug choices and doses often need careful adjustment for these patients.
Good point. Need to be careful with any meds.
Very careful.
Okay. So, looking down the road, what does the long-term outlook and management look like for a pet diagnosed with PSVA? What's the overall prognosis like?
Long-term management really involves regular checkups, monitoring their behavior at home. Are they bright? Are they having any subtle HE signs?
Yeah.
Tracking their body weight and body condition score, and periodic laboratory tests are usually recommended.
Rechecking blood work and urine?
Yes, things like the CBC, biochemistry profile, and urinalysis to monitor liver parameters, check for anemia, look for those crystals, and assess overall health.
What about the bile acids after surgery?
That's an interesting point. In small breed dogs, especially those suspected of having concurrent microvascular dysplasia, MVD, those post-meal total bile acid levels might remain somewhat elevated even after seemingly successful shunt ligation.
Still high, even if the surgery worked. Why?
Because the MVD, the microscopic vessel issue within the liver, might still be present and impairing the liver's ability to fully clear the bile acids, even though the main shunt is closed. So persistently high TSBA in these breeds doesn't necessarily mean the surgery failed, especially if the clinical signs have improved and maybe the protein C level has increased.
Okay, so interpret post-op bile acids with caution in small breeds.
Exactly. Consider the whole picture. The potential complications we discussed with surgery, like portal hypertension, thrombosis, seizures, can sometimes become long-term issues or require ongoing management if they occur.
Right, those risks don't always just disappear.
No. And it's worth noting, if multiple shunt vessels are found during the diagnostic imaging, say on ultrasound or CT,
More than one shunt?
yeah, finding multiple acquired shunts usually points towards underlying portal hypertension from some other liver disease, maybe cirrhosis or something called portal vein hypoplasia or atresia, where the main portal vein itself is underdeveloped. In those cases, trying to ligate the shunts is generally contraindicated because it would worsen the hypertension.
Okay, multiple shunts usually mean don't operate on them.
Generally, yes. That's different from the single congenital shunt we've been focusing on. PSVA itself doesn't cause portal hypertension or the development of acquired shunts.
Got it.
Now, the response to surgery, as we said, is quite variable, but overall, the sources suggest about 80% of symptomatic dogs show significant clinical improvement after ligation.
80% improve. That's pretty good odds.
It is, definitely. However, some patients, even after surgery, may still need some ongoing medication like Lactulose and dietary management for residual HE signs, maybe long-term.
May still need some support.
Yes. Cats, unfortunately, seem to have a higher risk than dogs of developing those secondary acquired shanks after surgical ligation of their congenital one. The reasons aren't fully clear, but it makes their prognosis perhaps a bit more guarded sometimes.
Cats have a higher risk of new shunts post-op.
Yeah. And interestingly, in some cases where only a partial ligation was possible initially, the shunt vessel can actually continue to close down gradually on its own over time, leading to further improvement months or even years later.
The body finishes the job sometimes with partial closure.
It can happen. There does seem to be a higher risk associated with surgery in very small dogs, under 5 kilograms or so. Dogs with certain severe changes already present in their liver tissue on biopsy, and, as mentioned, in cats.
Higher risk groups.
And recurrence of shunting can happen sometimes years down the line, maybe if the ligature loosens or new vessels form. So long-term monitoring is wise.
Okay. What about the dogs that don't have surgery, the asymptomatic ones or those managed medically?
For dogs that are asymptomatic and perhaps diagnosed incidentally, or those whose owners elect for medical management only, they can still have a good quality of life and a reasonable life expectancy with careful, ongoing management, the right diet, maybe a lactulose if needed, regular monitoring. They might not live quite as long as an unaffected dog, but they can often do well for many years.
So medical management can still offer good quality of life.
It certainly can, yes. It's a very valid option, especially when considering the risks and costs of surgery.
Right. Okay, so to sort of bring our deep dive into PSVA towards a close, the key things for you, the listener, to remember are that it's a condition pets are born with where blood bypasses the liver. This can lead to a whole range of potential health issues, or sometimes really no outward signs at all.
Exactly. And diagnosing it involves putting together clues from the history, the physical exam, specific blood tests like bile acids and protein C, and usually advanced imaging like ultrasound or CT to confirm and map the shunt. And maybe a liver biopsy.
It's like detective work. And the treatment options span from really crucial tailored diets and medications to manage symptoms, right up to surgical correction of the abnormal blood vessel, which offers a potential cure but also carries risks.
That covers the main points well. What's truly striking to me about PSVA is how profoundly it underscores the liver's absolutely critical role as this sort of gatekeeper and processing plant in the body. It's filtering out harmful substances, manufacturing vital things.
Doing so many jobs.
So many. And when that gateway is even partially bypassed, as we see in PSVA, the ripple effects throughout the entire system, brain, gut, urinary tract growth can be really significant. It just highlights how incredibly interconnected all of our biological processes are.
That's a really powerful thought to end on the interconnectedness. Maybe a final question for you to ponder is, consider the potential for these asymptomatic cases and the known genetic links in certain breeds. How might earlier, perhaps non-invasive screening tools evolve in the future to catch this condition even sooner?
That's a great question for future research and development in veterinary diagnostics.
Definitely something to think about. If you, our listener, find yourself wanting to explore this fascinating and complex topic further, or perhaps you have concerns about your own pet, we strongly encourage you to delve into the resources available through your veterinarian and trusted veterinary websites.
Absolutely. This deep dive has hopefully offered a solid foundational understanding, but it is a complex condition, and professional advice is always best for individual pets.
There's always more to learn. Thanks for joining us.